Uh, Good afternoon. I'm Sergio Aguilar-Gaxiola, and I'm a professor of internal medicine at UC Davis, and I'm also the director of the Center for Reducing Health Disparities also here at UC Davis. And what I'll be speaking about today is we'll be talking about health disparities. And I'm going to ask you if you can, if you have questions, please write them down. And as soon as I'm done, unless there is something that you would like to address at that moment, but if you can wait until the end, I would appreciate it. But I'm very glad that you are here. So let me start with. I don't know if you knew that ethnically and culturally diverse populations receive less preventive care, receive lower quality health care. When they make it into the doors of service, the quality of care is not that good. Also experience more negative outcomes, and also their life expectancy tends to be lower than white populations. The other thing that I want to share with you is very specific outcomes that highlight and in many respects illustrate the issue of healthcare disparities. One is that whites are 4 times more likely than African Americans to get coronary artery bypass grafting. So when they are in need of this kind of interventions, there is also this difference. Also, that older Asian American women have the highest suicide rate of all women over age 65 in the U.S., that also African American and Latinos receive less pain medication than whites for long bone fractures. And finally, another example is that Latino women suffer the highest rate of invasive cervical cancer and are far more likely to die from cervical cancer than their white counterparts. And a little bit about a topic that is of great interest to me and that we have done research in this area is what happens with those populations like the ones that we have plenty of here in California who have a limited English proficiency. And there are several things that have emerged in the research that had been done comparing those who don't speak English with those who are English proficient. And you have some examples on the screen, like limited English proficient populations are more likely to receive care in emergency rooms and then also have less access to private physicians. Actually, what we have come to appreciate is that ethnically diverse and culturally diverse populations often don't come for services until basically they are falling apart. They need to go for services and go to emergency care. The other one is that they receive less than optimal health care, and this speaks to the quality of care that these populations receive. Also, less preventive care, are at increased risk of experiencing medical errors. Safety is a big problem because of communication problems that leads to miscommunication, of course, and also leads to medical mistakes. Have fewer physician visits, are less likely to return for follow-up visits. Just to give you an example, in Latino populations, those who make it into the door of services, there is some data that shows that up to 75% of those don't return for a second time. And one has to wonder, what kind of experience they had, once they made it into the services. And I can tell you that there are issues related to culture and certainly of language as well that is involved in these very significant dropout rates. Also, they tend to be less satisfied with their healthcare. There is a study that actually a report that was created by the Institute of Medicine. How many of you have heard about the Institute of Medicine? If this is the area that you are interested, I would strongly recommend that you look at the Institute of Medicine, that they are constantly releasing very important reports, because the Institute of Medicine is one of the institutions in the U.S. that brings together the utmost experts in whatever fields they are working on. And they, after meeting, let's say, for a year or a year and a half, they create a report that tends to be very, influential. Like it is this report that you see here. Back in 2001, 2002, the Institute of Medicine released this report titled "Unequal Treatment," and I'll be talking a little bit more about that. But just to let you know that one of the key findings of this report was that there were disparities in all of these areas, from cardiac care to diabetes management, to treatment of HIV populations, pediatric care, all the way to mental health and many surgical procedures. And in fact, and I'll tell you about that a little bit more a few minutes later, because thanks to that report, it really triggered a national debate on the importance of health care disparities, and specifically on quality of care. The report doesn't deal with access to care, which is another issue. But let me go back a little bit and ask you, what is it that comes to mind when you hear the word disparities? What do you think that disparities mean?
Inequality.
Inequalities. Okay. All right. Any other words that come to mind? All right. Well, you are right on target. It is related to, actually, the most simple definition is this one, which is differences between one group with another group. When you compare groups in any attribute, it can be related to access to care, or to, who gets amputations because of diabetes care and who doesn't, or who gets treatment, for example, pain medication for certain health conditions. And when there is a comparison between more than one group, one with another, and it can be sometimes more than two groups, those differences are said to be disparities. This is a definition that you see here. Is a very common definition. Differences in the overall rate of disease incidence, prevalence, morbidity, mortality, or survival. And these words like incidence, prevalence, morbidity, these are words very much associated with the field of epidemiology. Like, for example, prevalence refers to the total number of cases, let's say, of diabetes or obesity or autism. And incidence refers to the new cases. Okay, you establish what is the total number of cases. Incidence is related to what are the new cases. Okay, so this is the most common definition. But disparities refer to differences in different areas, and you have some of them here, like health status. So it would be people who suffer from sickle cell anemia or hemophilia, or cervical cancer, breast cancer. That would be the health status. But also there are differences in access to, utilization of, and quality of care. Also on specific health outcomes, but also on the environment that, by the way, we are, in the last few years, researchers like myself have come to appreciate the importance of the role that the environment plays on these outcomes, like disparities. So how do we measure health disparities? Well, there are different ways to do it. And this is a very complicated area, actually, because it really is very much related to values, the kind of things that we value. And there are tremendous differences in which that people differ in terms of what they value. So things like life expectancy, infant mortality, the frequency of chronic diseases, and if there are differences by ethnic groups. Also healthcare, what is recommended and what is available or delivered. Also access to care, which two of the main issues there is affordability. Who can pay for the services that they receive? So insurance rates plays a very important role. But not only that, there are barriers to care, which can be individual or can be, based on the organizations that people go to try to receive services. But there are also issues related to geographic and provider level differences, and I will illustrate with some examples a little bit later. Also, the availability of culturally sensitive, trained bilingual mental health professionals, which has been found to be of critical importance because of the diversity of the patient populations that are being seen. So let me just illustrate. This is the percent of uninsured individuals by race and ethnicity, and what you have in the bars there, differences between white, black, and Hispanic. And that tells you those significant differences from 34% uninsured in Hispanics to 14% of white. Tremendous differences. Also, there are differences by the federal poverty line that you have there, less than 200% versus 200 or more. Significant differences there as well. So this is the way in which disparities are measured and showed to the public in general. This is about the California health workforce diversity, and if you take a look at the column that I'm highlighting in red, what you have there is these are primary care providers. Here in California, we have roughly 59 per 100,000 population, and this is below the national average that is 79 per 100,000 population. But one of the stories that I invite you to pay attention to is, if you see there, whites primary care providers are 53%, whereas the distribution of the white population here in California is 41%. Asians is 21% of the primary care providers, and their distribution is 12% in the California population. Latinos, big disparity there, whereas Latinos comprise about 37% of the California population. Only 5% of the primary care providers are Latinos, and so on. And this is not only on primary care providers. The same thing happens, for example, with psychiatrists. You have the numbers there, a tremendous differences in terms of the representation of psychiatrists in comparison to the proportion in the population. So those are some of the examples that I wanted to highlight. So what is a disparity? Once again, well, let me contrast between what is a parity and what is disparity. Parity refers to equality in amount and status, for example, in access to services, and also differences in living and work environments. And I'm going to return to that because the places where people live, where people socialize, where people work, play a critical role in their health, as I will try to illustrate later to you. So in contrast, disparity refers to avoidable differences in all of those things that I list there: disease outcomes, clinical services, clinical settings, etc. But disparities are not inequalities due to age or genetics or personal preference. Some people prefer not to use the usual, clinical services. They prefer not to go to a hospital or a medical center. They prefer to use, full healers and believe me, I have come through the years, I have come to appreciate that. There is nothing wrong with that, because that helps in many respects for certain populations. But what is important is to have a good sense about the difference between what is a disparity and what is not a disparity. How many of you have heard about the word equity? Okay, some of you. Okay, well, I'm going to talk a little bit more about equity now, because disparities began to become very popular here in the U.S. and in the world. Although in some countries, like in England, for example, they prefer to use inequalities as opposed to disparities. But the use of the word disparity has been evolving, and now has been replaced more and more by the word equity. So equity is a system of fairness, actually. When we talk about disparities, is to highlight the negative. When we talk about equity, is to give a sense that there is a sense of justice and fairness in this particular word. And it refers to all people that have a full and equal access to opportunities that enable them to attain their full potential. Another thing that I want to highlight there is that equity in healthcare, specifically in healthcare, because we can also discuss health status or health outcomes. Equity in healthcare requires that resource allocation, how the resources are being distributed to healthcare be determined by the health needs of the populations. There are tremendous differences in what is it that the different populations need. So what is inequity? Well, these are differences that are systematic, pattern, and unfair. And I will read this quote because I think that it will capture, and I think that for the rest of the talk, the topic that I'm talking about. So differences in well-being that disadvantage one individual or group in favor of another. These differences are systematic, pattern, and unfair, and can be changed. Inequalities are not random. They are caused by past and current decisions, systems of power and privilege, policies, and the implementation of those policies. One of the things that I want to emphasize, and once again, this is something that we have come to appreciate in the last few years, is this issue of determinants of health. What is it that determines the health of populations? And I don't know if you know, what do you think that is more important to determine how long people live? Is that they have access to the best quality of care when they get sick? Or is it where they live, the specific zip code where they live? What do you think that is more influential in how long people live? Do you have a sense? Come on.
Well, they're
don't
connected.
don't be shy.
So they're connected because where you live depends on where you can get health care.
It is a very good response. But do you know, it is what is unequivocal, and it is just stunning, actually, is that it is where people live more than anything. I will illustrate towards the end that point, but you know, if we don't pay attention to things like poverty or things like neighborhood safety or access to food or access to a safe environment so people can just leave their homes and walk around, that can be much more negative and much more devastating to the life expectancy than if people were to have to the best possible quality care. Okay, so it is where people live. And what is amazing is when you see that in a matter of 2 miles, there are populations in certain zip codes that they can live 10 or more years than just down the road. Okay, in other neighborhoods that they have their life truncated on average by 10 or more years. Okay, so what influences inequity? Well, we know now that there are social factors, economic factors, and environmental factors, and all of these combined make what is now called the determinants of equity. So, and these are some examples, and later on I'll come back to this point once again. So there are social determinants of health, things like gender, socioeconomic status, whether people are employed or not, the level of education that they have, having access to secure food, the availability of housing and transportation, which is a huge issue for some populations, things like racism and access and the quality of care that people have at their disposal. There are also behavioral determinants of health, like the patterns of overweight and obesity, exercise, and the use of substances, environmental, like the exposure to problems with water, having no clean water, as it happens, for example, here in our Central Valley in California. Also, exposure to pesticides, that is related to asthma, those kind of things. But there are also biological and genetic here, like a family history of heart disease and other conditions like hemophilia and cystic fibrosis. So, coming back to the report that I told you, this report by the Institute of Medicine, An Equal Treatment is called. This is, once again, a report. How many of you are really interested in health disparities and want to know more? Because if you are, I strongly recommend to get into Google and get into the website of the Institute of Medicine, and you can download for free all of these reports. And it is an incredible wealth of information that if this is an area that you are personally interested, that you will really be much more enriched by it. So this report was published back in 2002, and really it brought to the forefront, right front and center to the nation, the importance about health disparities. There are other reports that are published every year, that like this one that you see here is called the National Healthcare Disparities Report. I'm putting here, the cover page of the 2010 report. This is a report released every year by one of the federal agencies. And it's called the Agency for Healthcare Research and Quality. And what they do is to highlight what's going on in the country in terms of having access or not access to care, and also the quality of care that people have. And for several years now. It is not just in 2010. There is a good news and there is a bad news. The good news is that there seems to be that quality of care appears to be improving for many groups. But access to care is not, especially for Latinos. Year after year, access to care, and this is in general, and this is nationwide. Apparently, there are issues in terms of the access to care. This is a slide with somewhat busy, but what I want to emphasize here is that what you have is the core quality measures, and what you have there is in different colors in the bars. The black is better quality, the blue is the same, and the green is worse. So there are some groups like the one that I'm highlighting with the red bar there, that when you compare Hispanics with non-Hispanic whites, they tend to have worse quality of their care according to the measures that are being used. But look at access to care. This is access to care. Tremendous differences still in the measures of access to care when you compare one population with another. But look at the one on the extreme right, the column. That is poverty. These are the populations who experience poverty. They are the ones that continue consistently for several years having the worst access to care. And this is something that, avoidable, something that can change. There is a national attention on this issue of health disparities, and I'm just putting some examples here. This attention has come, in different sectors, not only the health sector, like you see on the first bullet, but also in business, in the business sector, like the National Business Group on Health. Also, in some of the plan initiatives, who is going to receiving, services like Medicaid, Medicare, those kind of things. Also, attention in the federal requirements, and also on the accrediting, agencies that provide accreditation for hospitals or clinics as to who can, provide services because they had passed their inquiries that they have about issues of safety or issues of communication and those kind of things. The other thing is who deals with health disparities in the U.S. If you want to know more about it, where can you go? Well, there are the National Institute of Minority Health and Health Disparities is one of the many national institutes that deals specifically with health disparities. But at the federal level, the Department of Health and Human Services, they have an Office of Minority Health. Also, the Centers for Disease Control, which is based in Atlanta, they have an office. SAMHSA, which is this agency also, a federal agency that focuses on substance abuse and mental health. Also, HRSA, which is the one that funds the federally qualified health centers, which are thousands and thousands of these centers, especially in the rural areas. And that's where people who are poor, and who have no insurance, that's where people go to. And then the Institute of Medicine that I told you a little bit about that as well. So can we explain why disparities are created? Well, there are many sources that contribute to disparities. There is not only one suspect that is related to that. The other thing that is important is not to play got you kind of a thing. It is there is no one to blame. And the other thing is that because a lot of the disparities happen in clinics when people go and go for services, that by the most part, I can tell you that there is no bad intentions on the providers on saying, I'm going to be treating this group of patients differently than how I'm going to be treating this other group of patients. So there are three levels basically contributing to disparities. One is at the provider level, those who provide the services. Another one is the health system level, delays in accessing care. I don't know if you or your family have recently been in need for healthcare services. Sometimes if you need certain kind of services, you have to wait for 2 or 3 months to get it. And those are issues that our health systems have to deal with. But also there are disparities related to the patient level. Like one example that I include there is the patient's mistrust. So how can we understand this issue of disparities in a more sophisticated manner? Because this is a very complex phenomenon. Well, one way to do it is to use a public health approach. Have you heard about public health? Public health is every day, I can tell you, that is involving our lives. Because thanks to public health, we are able to have vaccines when we need them. We are able to get antibiotics, when there is an infection for conditions like HIV or just skin infections or during the flu season, just flu. So public health is really affecting our lives in daily. So one way to understand is to look at these three big areas. The social determinants that I already told you a little bit about that, the interventions that can be available for that, and also specific outcomes. And very quickly, let me just share with you some of the examples related once again to the social determinants. So we have poverty, whether people have access to housing, stress, the level of education, access to care, etc. And the one that I want to emphasize once again is the social determinants, because at the end, I would like to share with you some facts about very much related to issues of equity and disparities, which are stunning. I continue to be very impressed by that, and I'll share it with you. What interventions are useful? And you have many different types of interventions, from culturally competency programs, social support, providing information to the public, policy issues, community-defined approaches, etc., and also outcomes, like what is it that people die of, or what is it that they get sick from, and things like well-being and stigma and the day-to-day functioning that they have. And this is a very busy model, but this is just to let you know how these things are very much related among themselves. This is an action model that came up in this document that appears every 10 years. If you want to know and have a scorecard of how the nation is moving in terms of health-related issues, there is this document called the Healthy People. Now we are in Healthy People 2020, but we had Healthy People 2010, 2000, 990, every 10 years, a group of, very smart people and experts in the field come together and they say, what is it that our nation needs? What are the things that we need to pay attention to and to focus on in order to make progress related to health? And then they establish goals and they say, by 2020, a certain percentage of the population should be less obese, for example, okay? Or the number of suicides should be reduced, okay? So it is related to that. So what I want to just emphasize is that the three circles that I show you, the determinants of health, interventions, and outcomes are pretty much demonstrated there. And one of the outcomes that, for the first time, at Healthy People 2020 included health equity, which is great because we are not doing that well here in the U.S. In spite of being the most powerful, economically powerful nation in the world, when it comes to different indicators as to how we are doing with all the money that is being invested, that we are not doing that well. Let me tell you, unfortunately, the U.S. Is on its way to from every dollar that is earned here in the U.S., about 20 cents is going to health expenditures. And our closest competitor is Norway and Switzerland, and they spent about 12%, 11 to 12% of the gross domestic product. And guess what? Those two countries have universal health care. Everyone has the right to have access to care, not here in the U.S., unfortunately. So we have a lot of work to do. The other thing that I want to emphasize is that when we talk about health disparities, it's not about race and ethnicity, okay? It happens with older adults. It happens with the LGBTQ community. Happens with people who live in the rural areas. All of them, all of these groups also are affected by health disparities. So I would like to just shift a little bit now, and shift because I have been discussing about health disparities, and my hope is that I'm not, that you won't come out of this, room thinking, boy, there are a lot of problems. Well, there are tremendous solutions as well, and constantly there are solutions that are being implemented, and one of the solutions that I want to emphasize is a solution that the AAMC. Have you heard about the AAMC? I see some noddings, but it stands for American Association for Medical Colleges. And this is a very important organization nationwide that deals with the medical schools, okay? And they play a very critical role in determining, the policies that dominate, the business that medical schools do. So not only the AAMC, but also the American Hospital Association and other groups came together, and they came up with this national initiative called a call to action to eliminate health disparities. And what I want to emphasize here is what you have right there on your right-hand side. 3 simple steps to provide some significant impact. One is data collection and use. The other one is to pay attention to culture and language, diversity in governance and leadership. These are things that, according to these institutions, it is of critical importance to pay attention to. How many of you know about healthcare reform? Hey, that's great. I see a lot of hands now. Very good. Well, it is also called the Affordable Care Act, or Obamacare, I even see some thumbs up. That's great. Just to let you know that there are a lot of, in the text of the over 2,000 pages of the Affordable Care Act, there are a lot of things related to health disparities. And some of them are included here. Consistent data collection, workforce diversity, cultural competence training and education, prevention program and promotion, and addressing disparities in healthcare reform in general. So now, let me share with you very quickly something that is very close to us here at UC Davis, and how is it that we are addressing the issue of health disparities. And this is just one example of the many examples that we have. One is that we started by collecting race, ethnicity, and language information in the medical records, okay? It's called the electronic health records, okay? And this was not being done several years ago when I joined UC Davis. And thankfully, after a lot of work and many people coming together, we finally, back in 2011, we included these three variables, race, ethnicity, and preferred language in the electronic health record. So now we have a sense of those who are using breast cancer mammographies, for example, or those who are using, medical checkups for coronary artery disease or, autism, you name it. It is possible for us to tell who is receiving the services by race, ethnicity, and preferred language. So we have this initiative to create these data fields in the electronic medical records. And we endeavor ourselves to inform the patients, the staff, and the community about, and also to train the staff about the importance information related to this. And then the idea was to create reports, because even though we are still working on that, I can tell you that it is very likely that we are creating disparities in the care that we provide, as there are, there is not a single hospital that I can tell you that they don't create disparities. And the important thing is what to do with them. Once you find them, how you can address them. So we created this kind of posters that were distinctively positioned in different places in the hospital in very simple language, and also we had it in different languages. We ask because we care, and because as we discover, sometimes when you ask questions about tell me your race, ethnicity, or preferred language, people ask, why are you asking me this? I'm coming here for an acute infection, and I have a sore throat, or I have this very high fever. Why are you asking me these questions? Well, this is one of the answers. We ask because we really want to know more about the quality of care that you are receiving or other people are receiving, and how we can make it better for you by looking at these differences that people have. So what we're hoping for is to identify and measure disparities, to create equity dashboards, to monitor trends and changes, and to achieve equity in quality of care. This is, at the end of the day, this is what we would like to accomplish. And we have, this roadmap that we created, and I won't discuss that much, just to let you know that we have, in a very systematic manner, we have address this issue, and we are hopefully close to starting to have, what kind of disparities we are creating in the medical center at UC Davis. And my hope is that we can come up with some specific solutions. Actually, I can tell you that we have a solution on a curriculum that we develop out of the center that I direct, called the Providing Quality Healthcare with CLASS. And CLASS refers to culturally and linguistically appropriate services standards. Okay? And this is to train people that once they find disparities, what is it that they can do with them? So they can improve the experience of care, and also improve the outcomes, and also hopefully reduce the costs. So let me just to finish, to provide share with you some conclusions. Disparities in access to and quality of care are evident, common, and pervasive, and they are unacceptable as well. Okay, I think that is so important to emphasize that. Ethnic group differences exist in access to and utilization of services, and this causes a tremendous burden on the people who suffer them, because it has a direct impact on whether they can work or they cannot work. Also, some ethnic groups are disengaged from healthcare. I gave you that, and shared with you that in the case of Latinos, up to 75% don't return for a second time. Because the medical services are not relevant sometimes to them. And there are strategies focusing on culture and language and attention to quality of care that seems to be promising. And we cannot wait to try some of these ones. So what is it that you can do? You came to this because you are interested in this topic. Well, there are several things. One of them is to, what I'm trying to do is to increase awareness about the existence of disparities. Also, for you to endeavor to know more about the evidence, who is affected and who is not affected, and what are some of the solutions that appear to be beneficial to achieve equity. Also to support innovative research to identify and effectively deal with the underlying social determinants. This is the ways in which you can get involved, to try to join a research group if this is an area that you're interested. To also, join clinical settings in which the services are provided, or in community settings, to get in policy work as well, and to volunteer your time. These are things. So finally, this is a question that I want to pose to you. If it is possible to improve population health by just focusing in healthcare, what do you guys think? Is it possible? It is perhaps needed, because when people are in dire need for emergency care, they need that care in order to continue with their lives. But there are other areas that are tremendously more important, as is illustrated in what contributes to premature death. What are the factors related to premature premature death. And what I'm illustrating there is that there are factors like behaviors, behavioral patterns, like genetic predispositions, like social circumstances or environmental exposure, and healthcare. If in order to avoid premature death, if you have the best possible care, access to the best quality care in the world, it's going to contribute to that important goal of avoiding premature death. Just 10%. 40% is behavioral issues. Is where do you live? Who do you relate with? Is the safety that you have in your neighborhood? Those kind of things. Do you have access to, quality food? Your diet, your nutrition. Whether you can exercise wherever you live because you feel that it is safe to do it. Those kind of things. That is more powerful than having access to the best quality care. Okay, let me stop here. We still have just few minutes. If you have any questions or comments. Yes, please.
So what are you doing to train medical students and residents to address health disparities at UC Davis?
Yeah, we are, with medical students all throughout the career, there are courses on the importance of culture and language. Cultural competence is called. One of my colleagues, by the way, who is the one who developed primarily the curriculum that I told you, providing high quality care with class, is the one who teaches the cultural competence classes. And along with that, there are many courses on health disparities, the importance of health disparities. And one of the things that we are trying to do is to put it in the Kool-Aid, to really try to put it in the water, because there is no way that in this era, if you are, hoping to, let's say, get into medical school, that you are going to not to experience these things. So we are doing it at the medical school level and also with residents. But we need to do much better than that. There are, we just hired at UC Davis a chief diversity officer that, by the way, he when he was asked recently, how to differentiate between equality versus equity. He gave a very interesting example. He said, imagine that you are in a classroom, and as you walk here, you are required to lift your shoes at the doorstep, okay? And then you put them in a pile. And then at the end, you are giving 2 shoes, no matter what size and what color and what shape. You are giving those 2 shoes, okay? That's equality. But if you want your 2 shoes back, or you want better shoes, even if they perhaps don't fit you, that is equity. That is related to your own needs, okay? So we have Dr. David Acosta now having joined us, and he's really looking to a framework that is very comprehensive, in which we can really engage in meaningful discussions with at all levels, medical school, residents, faculty, and staff, and the patients. This is a new era, actually. One of the key factors that we have been leaving out are patients, and we have to engage with them in a meaningful ways with them. So because at the end of the day, they are the ones, the ultimate beneficiaries of whatever we do in medical schools and certainly in medical centers. So we are doing some things, but not enough. I think that we ought to be doing much more, and we are on the way on doing that. Any other comment or question? And I know that the time is almost up. Well, thank you so much for coming. I appreciate it.